So we will start out today with our cardiac, our respiratory first. I did have a chance, believe it or not, to make a new cahoots to go along with it, so that we can making sure that I'm covering all my concepts I need to do with you guys. And today is week 5. We have, what do we have to do? You did your quiz already. We have discussion question number 3 that is up for 4, and we have now discussion question 4 for week 5. And we see some more NCLEX questions coming up. The NCLEX questions are just in the pediatric section now, so you don't have to worry about, going to growth, development, and going through those different ones to get the different areas. So I've already gotten quite a few requests for your pediatric assessment project. This is a good week to do it if you want to at least start it. If you send them in and you put them through the grade book, you can always resend it in. I want you to send it to me. Let me know. I will go and I'll grade it. I'll tell you where it's deficient or where I see little, maybe it's not as correct as it should. But I will give you a chance to redo it or change whatever I'm telling you needs to be changed or add what I think you should add, and I will increase your grade. It is 6% of your grades. It's just like doing all of your case studies, more than all of your NCLEX. So it is a big project. So just let me know first before you start what your project is. I don't want all of the same things. Yes, Jonathan, can I help you?
Yes, ma'am. Just for clarification, when you say send it in, is that where we would email you and say, hey, I'm going to pick this subject for my project. And then once you approve it, we can do it and, see how it goes.
Yes. Yes. Once you get the approval, just go ahead and put it in your grade book. Just send it in under, that assignment. That doesn't mean that that's your final, because I have multiple uploads there, and I've made sure that you can resend them in. Okay. And it's, this is now week 5. It's due week 8. What else is due week 8? You've got MedSurg 2 exam, you've got a community project due, and you've got this due. That's why I'm trying to tell you, if you do it earlier, it's going to relieve stress from you. So I'm just trying to help, plan your term for you, okay? So any other questions, anybody? All right, let's go for today. So actually, I think these are probably my 2 favorite parts of nursing, respiratory and cardiac. I've always been a cardiac bug. I was that nurse. I did 10 years in the cardiac ICU at Nicholas Children's, and I absolutely love it. And I worked the night shift, so I got to do a lot more hands-on type things, and I thoroughly enjoyed it. So respiratory, cardiac go together. If you don't have lungs, you can't breathe. And if you don't have oxygen and the heart doesn't pump it through the lungs, you're not going to live. So heart and lungs work hand in hand to each other. And we're going to see how that works as we go forward. So respiratory. What is the respiratory system? It's the lungs and all the oropharynx. It's the nose, the ears, the throat, the trachea, the bronchus, and then, of course, your lungs, okay? And there's different ways we know where an infection is, what's causing the problem, according to even some of the sounds we hear with these type of conditions. Now, one of the things that we know, upper respiratories are usually a virus, usually. I mean, yes, of course, occasionally it can be something. Usually in children, young infants, Haemophilus influenza is the cause of these upper respiratory. That's why we do tell them to get that immunization at 2, 4, 6 months. That's one of the ones that we really want to prevent some bad things from. Now, RSV, or respiratory syncytial virus, is the name of an upper respiratory infection. Now, for me and you as an adult, it's common cold, is exactly what it is. But as an infant, think about this. Infants breathe with their nose. That means obligatory nose breathers. Then you get sick and you put mucus in the nose. what happens? They need to suck, swallow, and breathe through their nose. They can't because it's clogged up with all of this mucus. So you are going to see respiratory symptoms like crazy, nasal flaring, grunting, retractions, tachypnea, right? You're going to see all of these things with it. Now, RSV in an infant is ages 0 to 1 year old. And that's the area that we are so more concerned with, because if they have another underlying condition, like just being premature and having bad lungs, or having cystic fibrosis, or any other immunosuppressive disease, it really could hurt that child. There is a monthly vaccine that we give for RSV called Synagis. And I'll go into that in a second. I just wanted to go into upper respiratories. I mean, me and you, it's just all symptomatic treatment. It's fluids, it is fever, pain control, and rest. That's it. Symptomatic is always going to mean that. Symptomatic viral pneumonia, same thing. It's going to be fluids, rest, antipyretics, right? That's all there is to symptomatic treatment. When we get the bacteria, we're going to be entering the antibiotics, but RSV is a virus. So we're just going to symptomatically treat them. Now, infants, I've talked about it several times already today and talking about how they really don't have an immune system. So at birth, mommy's immune system is given to that child, right? So that baby has got a really good immune system when they're born. But we know blood cells die, and all of this immune system tends to go away. And usually between 3 to 6 months, that immune system has lessened to enough where these infants are going to start getting sick. Now, they start getting sick. Yes, they're going to produce their own immune system right around 9 months. That starts to happen when they can do that and use immunizations and make it into their own. And we could keep it holding there in case we ever get that infection, right? Now, toddlers and preschooler, what do they do all day long? Well, they're in daycare mostly, right? They play all day long. And what do? They take toys and put it in their mouth and give it to the next kid. And they swap spit all day long. And this is how the viruses, bacteria, ear infections, everything goes around daycares. And that's just what happens. There's nothing we can do about that. As much hand washing, cleaning, disinfecting, actually, these children need it, because by the time they get into school, now their immune systems are strong because they've gotten all of these little things all the way through. I mean, how many times you put your child into daycare and it's like every week I'm going to the doctor, they've got some sort of ear infection, sore throat, something going on. That is normal for that. Now, as we get older, it becomes more bacterial type things because the viruses, we've had them. We've got that immunity, right? Because we know immunity comes as we get older and we've had the diseases and had the immunizations. Now, upper airway, oral pharynx, mucus. Where does mucus go? Well, we could spit it out, we could blow it out, but also it goes up into the ears. It's like the areas of least resistance. These are short, wide open tubes that go from the back of the throat up into the ears, and it fills up with mucus. It's always a bacteria. You always have bacteria in your oral pharynx, and it's usually staph, always. So how do you treat otitis media? Number one, pain control. Number one is pain. You can give an antibiotic, but it's still going to hurt. These things hurt. Have you ever had an ear infection or have a small child? It's like, oh, and they're crying and there's nothing you can do. So priority is to solve that. And it would be acetaminophen or ibuprofen. Older kids, I try a heat pack or a cold pack. Young kids don't want any part of touching any of it, but maybe an older kid gives them something to distract them with. Does it work? Well, maybe not, but it's a distraction. But once they get that, I usually will give ibuprofen, believe it or not. I think it's a better drug for the anti-inflammatory. I don't know, it's the way I think. And usually about 20 or 30 minutes later, the pain goes away. Then the doctor comes in and examines. They can look in the ear because it doesn't hurt. So again, Your priority in ears will always be, first of all, pain control. And I've already said that everything's open and wide, and that's why it goes there. So children who are sick, upper respiratory infections, what do they look like? Well, these children, number one, they're going to stop eating, stop drinking. They are going to probably complain of that acute pain in that ear, and that's your priority there. And they're going to have a little fever. Usually, with that just not eating, they usually won't vomit, but sometimes just a fever and one vomit could lead to upper respiratory going on. So we take that seriously because kids don't normally just vomit for no reason. But again, you're going to see the pain, the fever, the not eating, the cough, the mucus building up, right? And of course, your lungs are going to sound all coarse because either it's that upper airway that's creating noise or it's in the lungs already. So then, what is our goal? Everything we do is to help that child breathe easier. So child's not breathing well, they're tachypnic. What's the first thing you do? Let's reposition them. Let's put the head of the bed up. Let them breathe easier, right? That's always number one. Open the airway. So that eases respiratory effort. If oxygen helps, put it on. If it doesn't, you don't need it. But again, just sometimes it's that positioning to have them calm, to rest, to be comfortable. And then, of course, knowing how to blow their nose, the tissues, put them where they need to do, coughing in their arm, etc. And we do reduce the temperature. And I've asked the question before, but I'll ask it again. Do we really need to medicate a temperature? Is it dangerous? It's not. It's not dangerous. Why do we medicate for a temperature? Well, how do you feel when you have a fever? You feel horrible. And once that fever comes down, you feel a little better. And what do children do when they don't feel well with a fever? They stop eating, they stop drinking. What do you need to do? What is the goal of treatment for this? Fluids, rest, and acetaminophen for fever to keep it down because they can drink better. So it's because of the fluids and getting that fluids in that we reduce the temperature. The only time a fever is dangerous is when you have no fever, 15 minutes later, 15 minutes later, you have 101. That spike quick of a fever is called the rate of rise. It's so quick that it comes that the head goes and it has a synapse and it has a febrile seizure. So it is just the rate of rise. Once you have a fever, you're actually safe. I have never seen a fever due to high fevers. And I think the highest one I've seen is 106.5. There was no seizures. 106.5. Yes. Very sick little child that came in. I'll remember that one for a long time. That kid looked sick. So reduce the temperature, get the temperature down. Now you can give nutrition, hydration, and then they'll be ready for a hug or maybe distractions by a game or TV or something. Now, infectious mononucleosis, the kissing disease, no big deal, right? And the answer is wrong. So mononucleosis starts with a sore throat and just that general flu-like symptoms. That's what they look like. It is caused by a herpes-like Epstein-Barr virus. Epstein-Barr is notably known for just feeling tired and no energy and just ache and pain everywhere. Flu-like symptoms, right? So this is the way that you will see a child that has mono and the outcomes. So these children go to their doctor, sore throat, don't feel well. They do a culture, they do a strep test, everything's negative. So they send them home on symptomatic treatment, fluids, acetaminophen, ibuprofen, and rest. That's it. See you at, next week if you don't feel better. Well, 3 days later, the child's still not feeling well. Send them back to the doctor. And the doctor says, well, we don't know why, but let's give some antibiotics just to be safe. Who knows where this fever and why they're sick? 3 days later, they're going to my ER on a Saturday morning. And they're saying, I don't know. He says his sore throat doesn't go away. He's been on antibiotics. And I go, okay. So what are we going to have to do? Well, we need to rule out, is this an infection or a virus? How do we do that? Simple, a CBC. What are the white blood cells? Are they elevated with a bacteria or are they normal, like a virus, right? In this case, it'd be normal. This child would have a normal white blood cell. But what else we would do is something called a mono spot test. And it looks for mono. And then it becomes positive. So this little boy, it was an 8-year-old boy, went through all of that. On a Saturday morning, his father actually brought him in. And I sat there and said, okay, your child has mono. What mono's the biggest concern is you get your glands get swollen. And what the biggest gland that we're concerned about is the liver or the spleen. It blows up like a balloon and they're fragile. And any sort of quick hit on it could rupture the spleen or the liver. So this little 8-year-old boy came in and we told him, you got to be careful, sports, no PE until you see the doctor, like maybe 3-4 weeks out, for right now, no activity. Tell your brothers and sisters, no jumping around and rumbling around at home. They have to leave him alone because we're concerned about that abdomen. So this little 8-year-old boy went home. I taught him, the doctor taught him. I sent him written instructions home, which described no contact sports. 1 week later, I was the trauma nurse on the primary, which means anything that came in, I needed to run it. That means I had to make sure everybody was there, everything was organized, and that I would be documenting everything. So we get a call. 8-year-old boy in the Everglades riding an ATV and fell off. This was this child. He blew his spleen and he was dead on arrival. Yes, ma'am. Yes, I'll never forget him. Yes, I was on, the doctor was on, that took care of him. And we both just lost it because we had taught this child so well. So why am I telling you this? If you want to be a pediatric nurse and you have any child that gets infectious mono, tell them protect their belly and tell them it is serious, that they could burst it like a big balloon. And don't tell them the whole story that, of a child from your instructor. Don't tell them that because that's scary, but to let them know, protect the belly. Avoid contact sports. So bronchitis, that's the most horrible of all of the upper respiratories. There's no mucus, it's dry, and you try to go to sleep and you're coughing and you can't sleep no matter what you do. This is the definition: dry, hacking cough, non-productive that worsens at night. Doesn't let you sleep. So how do we treat it? Well, analgesics for either pain. Usually there's no fever with this, sometimes, but usually not. The antipyretics you need, humidity, and then some sort of cough suppressant. They would give cough medicines with codeine, but today you can't get codeine. So whatever cough medicine you could get, that will help suppress it so they can rest at night. Now, croup. This is the one that children sound like a seal. They sound like they're barking like a seal. And it's the upper airway gets all swollen. Again, it's H influenza one. So you can see why H influenza, we really need to make sure they're inoculized against those type of things. Now, usually it happens in children less than 5. And croup, it usually is a viral thing that happens and you have this big barking cough. Now, it usually, you've been sick, and then it just continues. So there is a difference between inspiratory and expiratory stridor, okay? So let me have you understand this. So with croup, the airway is swollen, so you can't get air in, right? You can get air out, but going in is hard. So there's inspiratory stridor. You're going to see, because you're pulling so hard, those substernal retractions. Of course, the barking is going to be there. Now, if we let croup go on and don't treat it, it's going to end up into acute epiglottitis. Now, what is an epiglottis? That's the leaf-like structure that covers the trachea when you swallow food or liquid so that it doesn't go into your lungs. With epiglottitis, itis, inflammation of the epiglottis, your trachea is covered. Air can't get in. It can't go in. There's no place. It is covered. Because of this, you can't swallow. You can barely talk. It's like whoa, 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 like your voice is there. You're drooling. It's like the old COPD patient where they're leaning tripod over, trying to find a way where that little piece of air I can open my airway to, that air can get in. So, what do you think your major priority on this patient is? Airway. So, what are you going to do about that airway? This is emergent. You need a tracheostomy tray, intubation tray, both at the bedside right now. Doesn't mean you have to get it, but you need to get someone to get in there now. You need to be next to that patient, all right? So, how do you treat airway, airway, airway? Number one, calm the child down. Put it in a mother's laps, whatever. Elevate the head of the bed, calm them down, whichever way is comfortable. If they want to be on the floor, I don't care. If they're having the troubles breathing, I'm going to do nothing to disturb them. And as long as I can monitor them, I don't care where they are. As long as they're somewhere where I can still continue to assess, right? So maintain airway. Somehow you got to get hydration in there. If it's severe respiratory distress, of course it's going to be IV because you can't feed a child who can't breathe. You want them just to breathe, not worry about drinking. We're also going to give some nebulized mist. Now, children, young children don't like that. They don't like all of that thing in their face. So how would you do it? There's tents we can do, but they're not going to want to go underneath that tent alone because it's plastic over them. So the parent can go in the tent with them, or they can take that big steam that's coming out, which will help loosen that airway, and have them sitting on their lap, blowing it in their face. And I think that probably is the most reliable, relaxing, and it will calm the child down, just being on their lap. Of course, mainline treatment. We're going to give epi. Why? We've got a swollen airway that can't breathe. We want it open. So give epinephrine. And what else is anti-inflammatory? Steroids. So how would we be giving them? Again, depending on patient status. Usually severe asthmatics, we get an aerosol going. We try to get an IV in so we could give IV steroids. But if this child is not acting right, we're not going to overdo them so that they, fight themselves into a severe respiratory distress. So RSV, I've mentioned it before. This is that ages birth to 1 year, first year of life, respiratory syncytial virus. It's a virus. So it's symptomatic treatment. It is fluids, antipyretics, and rest. But as I said, some infants don't have any sort of oomph. There's no extra in them to fight any infections. This, most of the time, are your premature infants, could be a cardiac, congenital heart defect problem, could be, one of those type of things. So we don't want them to get it. There is, for the first year of life only, an immunization that we give monthly, and it's called Synagis or palivizumab. It's a biologic. And we give that once a month, and it prevents the bad RSV so that these children don't get into that I can't breathe, suck and swallow, and go into respiratory distress. Another oral pharyngeal type thing is highly common in children is their tonsils and adenoids and having surgery. I mean, I could ask any of you how many have your tonsils out, and over half of you would tell me you did. So what do we need to know about tonsils? They usually come in, have surgery, we recuperate, and we send them home. This is usually a day surgery. Usually, unless there's other things going on with that child, they're sent home. So we need to know how to send this child home for the best care. So avoid irritating and highly seasoned foods. It'll burn the throat, like no lemons and oranges and citrus, and those things will burn, right? No gargling or vigorous toothbrushing. Do you know what they do for tonsillectomy? The side of the throat, the tonsils stick out. They take a scalpel and they cut off the tonsil, and then they cauterize the area. So what's left is big scabs on either side of the throat. So the tonsils are higher, the adenoids are lower. And all of that is a big scab. So you can understand why no vigorous toothbrushing. You might take a scab off and cause profuse bleeding, and I've seen that too. Try not to cough, clearing the throat, nothing in the mouth. Using analgesics, usually these children just needed some acetaminophen. And then older kids, an ice collar. Young kids don't want any part of it, but that ice does help comfort for pain. And then, of course, they don't need to be up and out and running around. They need to have their activities, limited. And older kids, having tonsils is all of that airway is pressure in the ears gets changed, and it feels like you're going up in an airplane and your ears feel bulgy. So if you chew gum, it'll help pop the ears, and that helps with ear pain, but only the older kids. So that's the difference, younger and older kids. Older kids are going to get an ice collar and they're going to chew gum. All right, now initially, to have a little odor in the mouth is normal. Okay, it's a scab back there. But if it keeps going after 10 days, now there's a problem. Go to the doctor. As in, it's persistent, it's getting worse, and it's just not improving. Of course, get to the doctor. And if they should be getting back to school between 1 to 2 weeks, depending on the child. Now, lower airway are your pneumonias. And pneumonias can be caused by a consolidation in a lobe. It can be caused by a virus, mycoplasma, pneumococcal, and we know we have a pneumococcal vaccine now because pneumococcal pneumonia is quite severe and hard for young kids, especially immunosuppressed, to be able to fight it. Bacterial, we're going to be treating with an antibiotic. But how do you treat viral pneumonia? It's symptomatic. Fluids, antipyretics, rest. That's the only difference. Just because they have pneumonia doesn't mean they need the antibiotic if it's viral. It's a virus, antibiotics won't work. The other way to get pneumonias is when they inhale. Years ago, it used to be baby powder. We all over the child, and they would inhale the powder, and we found out they were getting pneumonias due to aspiration of this powder. So we do not recommend having any baby powder around children. Another way of aspirating is feeding. Infants, a lot of them have a lot of spit up all the time. And with that spit up, they could inhale, aspirate, and cause pneumonias. So all of these things. Now, another thing kids do is put everything in their mouth, right? I just mentioned about cognitively delayed younger kids worried about small objects. Well, the most common coin of all the coins I've ever seen is a quarter. They don't pick dimes or pennies. It is always a quarter, the biggest one of all. Could you imagine that? So what do we do when we have this child coming in with a foreign body aspiration, right? Well, number one, do we have an airway? Is the child breathing? What they do with this child is usually they come in and it's sitting there and it just hurts and they need it getting taken out. Now, they used to send them in for a bronchoscopy, put them under anesthesia, send them to the OR, go in with a scope, with a little clamp, pull it out. But this requires a OR stay and maybe an overnight for recovering that child post-op surgery. So what they do now is they take a Foley catheter, they put it down below where that coin is, blow up the Foley catheter, the balloon on the end, have the kid sitting on the surgeon's lap, believe it or not. They lean forward and they pull it out. And you'll find they'll vomit and they will, the coin will spit out. And then you'll just watch them afterwards. Pertussis. Now we've got a vaccination for it, and that should be all right. But we still have some people who do not believe in vaccinations. And because of that, we've had some incidences of whooping cough around there. Know that it's extremely, extremely contagious. So if you work with children and you have to place a child in a room with an upper respiratory, knowing if they've had any vaccines or what they've had can help you place that child better. Because I wouldn't want to put this child in with another child that could also possibly get pertussis because we didn't check out, did they have that immunization or not? Smoke inhalation, this happens, where they don't know what's going on and they're getting all the smoke and CO2, and basically it's airway and it's 100% oxygen we give, trying to blow off the CO2 and, find out the damage to the lungs. Tobacco smoke, big thing, effects on children, causes ear infections. That's a big thing with environmental smoke, and causes infections as it is on children. So never should anybody be smoking around children. That smoke can harm them. Now, another big concept in respiratory is cystic fibrosis. This is an immunosuppressive disease. This is congenital. It is mom and dad have the disease, your child is going to have that chance to get it. Now, at birth, in cystic fibrosis, if you didn't know your child had a possibility of having cystic fibrosis, this would be a child that would not have a stool. This is one of these ones. And you're going to hear me say several different conditions, but this is the first one. Cystic fibrosis, if they're born and they have cystic fibrosis, we're going to see them not having a bowel movement the first 24 to 36 hours of life. And it's one of the things we will check for. Now, if we had that child and we were suspecting, what would we see? Well, number one, there's three things that happen. They sweat salt out of their skin, and you can lick their skin and it tastes like salt. It's really salty, all right? The second thing is their lungs are clogged, full of mucus. And the third thing is their small intestines lacks pancreatase, which digests fat. So now we're going to have a nutritional problem along with all of that. So salty tasting skin, coughing, lots of phlegm, lots and lots of infections. All that mucus is like petri dishes waiting for bacteria to grow there. And of course, it's going to be that wheezy, shortness of breath. You're not digesting fat, like I said. So fat's coming out in the stool. So foul smelling, greasy stools, you'll see. And because fat is the highest of all calories of any component of carbohydrates, proteins, fats, it's the highest calorie count. You're going to be that small child. You're not going to have poor growth, poor weight gain, because you're not getting those calories. So what are we going to do? Number one, how do you diagnose cystic fibrosis? Babies born at birth had a meconium ileus, no stool at birth, right? We are going to be doing a sweat test. And all it is an electrode that you stick on the skin, and it measures the amount of sodium on the skin. That's as simple as it is. Once we determine that there is a positive sweat test, this child we are going to be doing several things for. First of all, we're going to be watching those lungs for infections. These children are going to be on antibiotics all the time. they're going to be having PICC lines with antibiotics all the time. I mean, it's a chronic, constant thing that you see with these children. They'll be on medicines to help loosen and get rid of all of that mucus. There's one that smells like rotten eggs that they take, but it does, it loosens it up and it gets rid of it very, very well. Also, chest physiotherapy. We're going to be giving aerosols, right? We're going to be opening the lungs, and then we're going to do chest CPT, get rid of the mucus, and then that child can eat whatever, meal, breakfast, lunch, or dinner. So this child is going to be chronically respiratory, CPT, and then we're going to be feeding them. Now, immediately before they eat, they have to replace the enzyme that they don't have in the pancreas called a pancreatase. That's usually the name of it. And this is a medicine that we must take before food, meals, or snacks. And it helps digest the food to try to get as much nourishment as we can out of what we're eating. There are some things that we need to know about this medicine. Sometimes they have these little capsules with these little beads. You cannot crush them. They're like enteric coated. You can't crush them or bite them or anything. You can take a capsule and you can sprinkle it on the food and you can take it that way if you need to. There's also powder. And if they take the powder, it's just like some of those medicines where you have to rinse the mouth afterward because the powder can harm the teeth and the enamel. And the one thing I think we forget all the time is as a child grows, we need to increase the dose. I see this a lot, especially like with children with seizures. They might have a seizure because they haven't had an increase of their anti-seizure medicine in a year and they grew 15 pounds, and that could make it that this child gets a seizure because of it. So again, making sure we're adjusting dose as they go. So the management, I've already gone through them. Let's look at it again. Airway clearance therapies. I mean, swimming in a pool underneath water, holding the breath is probably one of the best ways of exercising those lungs. Using the bronchodilator medicine and then doing chest CPT to get rid of all the medicine. Another thing about these aerosol stuff, making sure they wash out the mask and stuff every night so they're not taking and transferring all of these germs from day to day to day, okay? Aggressive treatment of pulmonary infections, as I said, we could give aerosols with antibiotics in it. Gentamicin, tobramycin aerosols, they're not uncommon. We put the antibiotic right in and it nebulizes into the lungs. And as I said, home IV antibiotic therapy, having a PICC line is not uncommon for a child with CF. So the GI stuff, let's replace that enzyme, that pancreatase. And we take it immediately before meals or snacks. Now, as I said, you're not digesting fat. So what sort of diet must this child get? Well, it's going to be low fat because they're just going to stool it out. It's going to just be diarrhea, right? So how do we get them extra calories? High protein, high calorie, low fat. That's all that you can do. Would you hold the salt shaker on this child? No, they're oozing salt out their pores. They need extra salt. You do not hold a salt shaker here. They can have rectal prolapse is one of the things, and they have a lot of reflux. So making sure that we do watch that. One of the things about cystic fibrosis, as I said, that the pancreas isn't giving us what we need to digest fat. So if the pancreas isn't working the way it should, it may develop into diabetes as they get older. So this is one of the big things we monitor, monitoring spot glucoses, right? I want to see what little random glucoses are on you, and then checking the hemoglobin A1Cs on visit. Is that glucose under control? Is the pancreas still okay? Because probability is very high of developing diabetes. Now, one of the things about cystic fibrosis is men. Men want to have a baby with their woman. Now, a woman with cystic fibrosis has the ability to get pregnant, but she will be a very high risk pregnancy, of course. A man cannot get a woman pregnant. Apparently, there's mucus in the vas deferens, so the sperm can't get to the woman. So apparently, when they do a bilateral lung transplant 1 year later, they have the ability to have children. Somehow this block goes away. I'm not sure exactly. It doesn't go into details. I've done a lot of reading about it, but 1 year later, they're able to have babies. So that's what this picture's about. Can you imagine that whole chest is open and they've taken lungs out just for the desire to have a baby with their woman? That's quite a lot to go through, isn't it? And they do it. Sleep apnea, just because you're a kid doesn't mean you don't have sleep apnea. Ever hear little kids snoring when they sleep? Happens all the time, doesn't it? Especially with all that oral mucus that they have. Knowing that same things that we're going to be doing. If they don't sleep at night, they're not sleeping during the day, and it can cause problems. So, we could put them on, do the sleep study and put them on BiPAP and let them know that it does help, just like we do with adults. Acute respiratory distress syndrome. Again, your lungs are completely shut down, they're not working. It's sometimes you will have, for instance, if you had an incident where a child was drowning underneath the water and would, quote, had drowned, pick them up and they revive and they're running around and they look fine. What can happen is because they've had that water enter the lungs and have had a hypoxic episode because of that. You can have your lungs up to 72 hours later all of a sudden respond to it. These children are admitted in at least a step down with an O2 sat monitor to make sure that they're maintaining their oxygen levels, because it can be a delayed reaction. That's one of the causes of drowning. There's also overwhelming sepsis. Any infection on a kid is always a big deal, because probably the first time they've had it, they're not used to those germs and they've got to have it. We have to help them fight it off. Of course, trauma and drug overdose is the other one. So how do we treat acute respiratory distress syndrome? Well, again, it's going to be a symptomatic thing. This is a picture of ECMO. I actually did get certified in ECMO, and it's an interesting concept. It's like a heart-lung machine, but it doesn't produce cardiac output. It pulls the lungs off, it oxygenates it, and it puts it back into the body. That's all it does. So it gives the lungs a chance to rest for whatever the reason was. And it could be any age child, from newborn to adults, doesn't matter. And they put this on just to let the lungs rest, and then they slowly wean it off. Many of these children do well, but they always say if they're on after a week, it's getting a little iffy there. So we try to get them on and off as quick as we can. I put CPR into this PowerPoint knowing that you're going to get questions on CPR. Is it 15 to 2? Is it 30 to 2? What's one man? What's two man? Go back and review those things. You're going to see those on exams, seeing those on your HESI to let you know. And then also remember, it's just not knowing CPR. It's also knowing that there's going to be a parent there. I think it's the hardest thing to watch a parent looking into a room where a child is being coded on and looking at all of that and be so overwhelmed. As much as possible, I like to have the mother there with that child in a position where they're not in nobody's way, but I wouldn't want a child to die without a mother there. Could you imagine? I wasn't even there holding his hand when they died. That would all they'd ever think for the rest of their life about their baby. So again, worry about those caregivers. Now, asthma. Asthma is expiratory, Strider, right? We have the upper airway, oropharynx, it's in. I can't get it in. Well, asthma, the upper airway's fine. I can breathe air in. But what happens with asthma? The lower gets swollen, right? And now air gets in, but it can't push out. So you're going to see this prolonged respiratory, expiratory, trying to get the air out of them. And it's usually due to some sort of hyper responsiveness to some allergen of some sort. Could be food, could be something in the air, could be something they touched, could be anything that could have caused this. So, management of asthma. Well, they're going to be doing all sorts of function tests, skin allergens, of course. If it's due to an allergen, we want to know. With children in any disease, we want them to maintain as normal a life as possible. So, how do you think we get a child with asthma be in normal activities? Well, if he's allergic to grass, he's not going to be playing soccer or football or baseball, right? He might be on the tennis team or the swim team, right? They've got to choose what works within them, but keep them normal. And our goal always is preventing exasperations. Those little things on the bottom with the little masks there, they are called spacers. If you ever get a child, even adults, that come in saying, I've been using my MDI, my little thing, but it doesn't work. You know, sometimes it's because they know how to push and inhale at the same time. It's like chewing gum and walking. Some people can't do it. But if we put that little mask on and put the thing in the end, even on adults, we do it on very young kids too, but push that dose, whether 1 or 2 squirts, they can inhale it and they can get it all. Young children might cry, but they're taking deep breaths in. So they're really getting the medicine in the way they should. So if you see a child that's not getting better, they said they have tried it, have them show you. How did you give yourself your little inhaler, all right? And most of the time you're going to find out they're not doing it right. Long-term care of asthma, again, it's always prevention, right? So we're going to be giving aerosols, those rescues as we need them. We're also going to be keeping away from any allergens as we can. We're going to be taking Singulair every night, right? That's right now, I believe it's ages 2 and up, we can give Singulair. And then, of course, they get that one aerosol morning and night, that prevention one. In adults, it's Symbicort, Advair, Brio. In children, it's called Pulmicort. It's the one that's always used. And those prevent those bronchospasms. And then, of course, you get into an asthma attack. What are we going to do? It's going to be corticosteroids and everything to calm that child down and get that airway open. Now, my husband, God bless him, he went to status asthmaticus about 7 years ago. He was in the ICU for 12 days. And the first night he went in, about 4 in the morning, he had, I don't know what happened. He went into acute status and he was in it for almost 12 days. He did not get intubated. And the reason is I could talk him down. I talked to you about calming your child down. I've got firsthand experience on an older gentleman that you can sit there, hold my hand, look at me. It's okay. Slow down. You're doing good. And I could talk him out of it. And he was on max treatment. There was nothing else except to intubate him. And I did not want that for him. He has not had, I'm knocking on wood, an asthma attack since, and he's really on top of it. It scared him, and me. We don't mess with that at all. That was my biggest concern during this. If it went and the hurricane came up and we had a lot of stirring on, how was his asthma going to act? But he's good. Oh, we got a cahoots now. Whoop, whoop. Any questions so far? All right. Where did we go? So as I told you, I broke these up again for you. I think that I like that. Testing you right away on what you know. Ashabash, huh? Okay. So who's going to win today? Jamaica, are you going to win? Maybe. Jonathan wants to. All right, I see you. Let's go for it. Pediatric respiratory system. A majority of upper respiratory infections are caused by what? So when we talk about URIs, upper respiratory, yes, it's always going to be most of the time viruses. As I said, Haemophilus influenza is the one that can cause RSV. So that's why we like to immunize against it there. You walk into a 6-year-old child's room and you find them not breathing and doesn't wake up. What are you going to do? What's CPR? Doesn't breathe. So immediately you start chest compressions, you yell for help, and then you start 1-man, 2-man CPR, whatever it is at that time. Another multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? So it's a little bit of anything, any aches and pains. I think the one thing that we see with small children is all of a sudden they stop playing, sit in the corner, and they don't want to drink their favorite juice. I mean, that's usually what we see and go, oh, something's wrong here. And then you say, oh, that's what's happening. Let's give some antipyretics. Let's get some fluids in them. Another multi. What do you look for when assessing respiratory function? So we look for a little bit of everything, don't we? The one thing about children, you can look at them and you know when they're not breathing well. You can see between their clavicles, it's pulling what I say to the background, a backbone. You could see it pulling straight back, or that nasal flaring in the younger infants, or that grunting. I mean, all of these things is going to tell you. I mean, what's the first thing we need to do is we need to, let's say, elevate the head of the bed. Maybe it's putting some oxygen on. I mean, that in itself can help just with that labored breathing. What would you look for after a child has a tonsillectomy? What's our biggest concerns? Remember, they've taken the sides of their throat, they take scalpels, cut it out, and they've cauterized, and there's big scabs on the back of the throat now. What is our biggest concern? This is our airway. This is where our tonsils are. I'm worried about bleeding. Now, swallowing more than usual is telling you something's going on. Now, the one thing you don't do is you don't open the mouth, stick tongue depressors in, because you don't want to do anything that can dislodge these clots. Now, I'll tell you another good story about a tonsillectomy. It was a girl who had had her tonsils done a week before. She had just gone to the ENT and got a clear post-op visit. On the way home in the car, she vomited blood and a big clot. So they rushed her right over to the ER. I was in the triage area where I was most of the time. And she came in and a clot the size of a softball was coming out of her. She was 8, 7, 8, 9, young girl. And she just proceeded to keep vomiting. Her heart rate was already 140. I didn't mess. I picked her up and ran her back to the trauma room, where I called the doc, I called somebody, we got an IV. This little girl got 1,000 mLs of normal saline to get the fluid back into her. She was sent back to the OR where they recauterized the area. So this is 1 week post tonsillectomy. So again, being careful. That could have been just manipulation of the doctor looking at there, making sure it was okay. So again, it happens. I've seen it. She was in hemovolemic shock on me. Fluid resus. A multi. Nursing care for a child status post tonsillectomy include so spicy foods, absolutely not. We just want to make sure we give pain medicines. Why? We want them to drink. They still got to drink, right? Again, no red fluids, no red jellos. We want to make sure it's nothing that resembles blood. Remember, gum is for the ears. It's like the airplane where they get all clogged. Older kids, ear pain is really bad, and that will help pop the ears and stop the pain. And ice always helps. Younger kids, they don't want it. A multi. What signs and symptoms would you see in a child with otitis media? So otitis media, they don't always have fever. They usually come in just the pain. And what they see with that is that loss of appetite. Pain, loss of appetite because they hurt. Now, if it gets to the point of purulent ear drainage, that's been an ear infection that now that has burst. And now that pus and whatnot's coming out of the ear. So again, all of these things. No fever though. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Tell you, probably this is the worst of all. I can't sleep. I'm just coughing, 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 coughing. What is it called? And it is called bronchitis. The other name, the medical name is tracheobronchitis. So trachea and the bronchus gets inflamed and it creates that bothersome dry cough. So it's either tracheobronchitis, bronchitis, it's the same thing. The monthly immunization for RSV is the monthly immunization is called Synagist. Humira is for rheumatoid arthritis. It's a biologic. Indocin, we're going to go in the cardiac land, and I'm going to tell you what that is next. And we know HIB has to do with those first immunizations we get to prevent that RSV and upper respiratories. A 4-year-old child's been taking meds for asthma, but they're still wheezing. What information is important? What do you need to know? They're taking the meds. They're taking their inhaler. You're still wheezing. And it's probably they're using the MDI without a spacer and they don't know how to walk and chew gum, right? They don't know how to push and inhale at the same time. And it's really interesting. Even the little tiny kids, the little toddlers, they'll take there and they'll do it themselves and hold it after a while. They get used to it. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? So an 8-month-old, what's normal? What's not normal? Respiratory distress. What are signs of respiratory distress? Remember, if you're in respiratory distress, your heart's going to respond and be tachypnic too. So an 8-month-old, normal heart rate, 100, 108, those are normal. Respiratory rate 25, there's no respiratory distress there at all. 95% for kids, above 92 is normal for children. Now, substernal retractions, absolutely, we're showing there's some sort of distress and the restlessness. Now we're becoming hypoxic. Signs and symptoms of asthma include all except okay, asthma, lower airway. Air gets in and it gets trapped. You have a prolonged, I gotta force that expiratory phase. The air's in there, it won't come. And you're just trying to get it out there. You're coughing, you're wheezing, you're short of breath, you're all of that, but you can't get it out. So it's prolonged expiratory phase. And you can barely even hear sounds at that point. What should you not do to children diagnosed with croup and epiglottitis or who just had a tonsillectomy? What don't you do? So again, keep out of that mouth. Don't do anything with it. You increase in the swelling and it will increase the issue. So don't do it. Nursing interventions with a patient with epiglottitis would include, so you get a child in, epiglottitis, they're drooling, they garbled voice, they're leaning over, tripod, they're restless. What are we going to do? What is our biggest concern? Airway, 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 airway. Have an intubation tray or have a trach tray at the bedside. You're not going to suction oral airway. You're just going to increase the swelling. Nothing goes in the mouth, not even a suction catheter. What you're going to have there is ready to intubate. Get ready for airway to be made. Which triad suspects epiglottitis? We have a lot of triads that we look at in nursing, right? We have some here on diabetes. We have some on, so epiglottitis, you have to know where the epiglottis is. It's in the throat, so it's a stored throat. If it's swollen and inflamed, you're going to be swallowing. You can't. You're also going to be drooling. Very good. A multi. Treatment for infectious mononucleosis. It's my poor little 9-year-old boy. So remember, mononucleosis is an Epstein-Barr-like virus. So no antibiotics, okay? This is all symptomatic again. Rest, fluids, antipyretics, and this one is protect that abdomen, no contact sports. I had 6 brothers. They would have to tell my brothers not to wrestle me all over the floor and beat me up because that would be happen. So again, protect that abdomen. A multi. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? So you're doing patient placement, and you need to get this infant into a room. Usually it has to go with another kid, right? What do I need to know? What's important? So I need to know immunization status. That's always number one. How do I place that child? Is it a pertussis? Is it something that's, something that an immunization can help prevent, or do they have it or not? Of course, you always want to know the fever and medications because you have to continue acetaminophen, ibuprofen, or whatever they've been on. And APGARs don't make a difference at this point. It's what's going on right now. How is cystic fibrosis identified? So newborn screening, they usually do it even when mom's pregnant now, and they usually know. And there's also that sweat test. And usually what identifies that they need to do it is no stool for the first 24, 36 hours after birth. That's one of the conditions. There's several more, but that's the first one you need to know. And then we do the sweat test. We just look to see if there's sodium on the skin. Multi. What is included in the plan of care for a child with cystic fibrosis? So CPT, absolutely. Remember, it's chest and it's also diet. So we're going to do aggressive chest physiotherapies. We're going to do aerosols before the chest physiotherapy, before they eat. When they're eating, we're going to give that pancreatic enzymes with meals, right as they're eating, not 2 hours before, not an hour after, right when they're eating. And of course, high protein, high carbohydrates, and because they're losing so much sodium out the skin, you're going to give them a salt shaker. There is no low sodium diet here. They need it. They're losing it. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, 32? So when we're looking at this vomiting, heart rate of 88 on an infant, we know that that's not a good thing. If they're vomiting and they're on digoxin, that might be the only thing they tell you. Doesn't mean that their heart rate's going to be that low already. But any child on digoxin that vomits, a little infant, this is the one that you're going to hold the next dose and you're going to call the doctor. You're going to be checking a digoxin level, a potassium level, seeing what's happening before we give it. This child could be in TIG toxicity. Which information is the most important when rheumatic fever is suspected? Rheumatic fever, you see many different symptoms. You're going to see a rash. You're going to see your nodules swollen up. You're going to see, could get up to a heart valve problem going on with rheumatic fever. What happens when you have a strep infection that is not treated or treated completely? It can cause rheumatic fever. The thing with rheumatic fever, usually the rash starts, the fever starts. It's when they start getting this weird sort of gait that they say, oh, what's going on? This chorea, it's called. Now, rheumatic fever is caused by a strep infection. The treatment is treat the strep infection, give them the antibiotics. Everything will be reversed except that heart valve, okay? That one's going to have medical or surgical treatment in the future. Signs of shock in children include all of the following except shock. What do you see? Well, I could go on and on and on the symptoms about shock here. So initially, elevated heart rate, decreased blood pressure, decreased urine output, poor capillary refill, altered mental status. I mean, this child is going to have low blood pressure, so it's not hypertension. So all of the above can be in shock, what I just said. Which of the following is the most common cause of shock in infants and children? Think about an infant. Think about, who they are. They have absolutely no immune systems yet. They haven't had a chance to build it up yet. So the one thing that's the most common is going to be infection. They don't have that backup. They have none of that backup. So most common infection that we don't catch, and they go into shock quick. They have nothing to fight it. Multi. Signs and symptoms of rheumatic fever include and remember, all of these things are caused from a strep infection. How do we treat it? We treat the strep infection by giving an antibiotic. And all of this will go away. Every single will go away, except if it's attacked the mitral valve. If it has mitral valve damage, it won't be corrected. It's going to have to be medically or surgically corrected. A child just had abdominal surgery and cannot cough well enough to expectorate secretions. What is the nurse's priority? How are you going to get them to cough? Get secretions out. They just had surgery. They hurt. What are you going to do? That's how I look at that question. So your priority is pain medicine. If you don't give pain medicine, they hurt. They're not going to be able to move, use incentive spirometry, get out of bed. You're going to medicate them for pain, then get them up, cough, deep breathe, out of bed, ambulate, do all the things. But how would you like to have abdominal surgery and get no pain medicine and get up and exercise and walk down the hall? Ain't going to happen. So the child, think of it the same way. Medicate for pain. An infant at 3 months has a fever of 103.6. What would you medicate this infant with? Only acetaminophen up till 6 months old. That's why this question is here. You cannot give ibuprofen until they're 6 months old. There's something to do with platelet coagulopathies, bleeding somethings with ibuprofen, and they cannot tolerate it until they're 6 months old. And then we would alternate acetaminophen, ibuprofen every 3 hours for fever. A multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? So we're going to do a little bit of everything. Now, elevating the head of the bed is only if the doctor has ordered it. Some conditions post-operatively can. I mean, I can agree with, yes, it can be there. That can help with the lungs and breathing better. Extensive spirometry if they can, using pillows and blankets. I used to use little beanie babies to hold up ET tubes, and then the children could look at them. They're half, zupped on, paralyzed, sedated, but they still could see. And they have their little beanie babies they can look at. Of course, keeping them clean and dry, whether chuck pads or diapers. And again, turning positioning every 2 hours. Same thing as we do with adults. Children do get foot drop. Children do get decubitus. All of those things do happen, so we have to prevent them. How can oxygen be delivered that is easiest tolerated and accurately monitored for infants? Easiest tolerated and accurately monitored. This is just for infants. and it's an oxyhood. If you look at nasal cannulas, they want to go like this and pull it off, and there's tape on it, and it rips the tape off their face. Blow by, they don't like that extra flow, and they're always with their hands and moving away. If you've ever been intubated, and I have been, it is not fun at all. But that big dome and just oxygen in there, they can suck their fingers or a pacifier, and they're just happy. And that's the easiest way for them if they can. Okay. What procedure are used to keep the lungs open with a child with cystic fibrosis? How do you keep them open? Remember, they're full of mucus. So a little bit of everything. And it's not ambulating PRN, I would say QID. It's not whenever you feel like it. When you have cystic fibrosis, you have to be very diligent and up and moving and exercising and ambulating. And as I said, put them in a swimming pool, probably the best place for them for their breathing exercises. But again, keeping them moving and lungs moving. Last question, a multi. Children with cystic fibrosis require pancreatic with meals. What teaching should be done? So you take them right before, you can sprinkle it if they want. They also rinse the mouth after the powdered one. And as they grow, make sure that they increase the dose as they get bigger. So that is that one. Oh, I see how we did with this one today. Kevin B, good job. 2, Lizzie, good job, Lizzie. Number 1, Mariah, good job, Mariah. And Brittany in a VRS. All right, we're just going to do now our cardiac. Now, the cardiac one, yeah, many of you get really, really, really nervous about it. I want you to know it isn't as hit as hard as you might think it. So let's go over just these concepts that go with it. Let's go start with the PowerPoint. Where are we here? And I think we're on number. There we go. All right, cardiovascular. Isn't this the one that scares all of you? A heart. How do I understand it? Well, what I want you to understand is the heart is a vessel, and off of it is a hose, a garden hose. And all that hose runs all the way through the body, and it comes back to the other side of the vessel and returns the blood. So think of a garden hose and think of a kink. And where that kink goes, the blood will flow backwards, right? Blood goes to the areas of least resistance, just like the mucus in the head goes up into the ears, areas of least resistance. So there's types of cardiac defects. There's congenital, and then there's the acquired ones. We mostly talk about the congenital ones, and we're going to go into what does that mean and how do you work with them. So here's our hose, all right? Doesn't that look like a big garden hose coming off the heart there? So I'm going to give you your first congenital heart defect. So first you need to do is understand, how does the blood go through the heart? No, it goes through the right side up into the lungs, back to the left side, and it goes to the body. And it goes through all of these different labels. Now, please review your anatomy, because what's the tricuspid valve, what's the mitral valve, and where are they? All right. So let's look at coming off that left ventricle is the aorta. And the aorta goes the aortic arch, and it goes down, and it goes to the body, right? There are times after those three splits go into the upper body, the carotid artery, vena cava, right? The that little arch there sometimes gets a kink. So there's a kink in the hose. What happens to a garden hose when you kink it? Behind it, somewhere there's going to be a squirt, whether back at the nozzle or if there's a hole in the hose, you're going to see water come out, right? Same thing happens with a heart. So if the blood is coming over the aortic arch and then it's kinked, there's a narrowing. It's called a coarctation of the aorta. So where does blood go? It can hardly go down because it's kinked. It's a narrowed. So blood can't go down. So what wouldn't you see? Well, if the blood can't go down to the feet, you're not going to feel a pulse, or a very minimal pulse you would feel in the posterior tibial, dorsalis pedal, popliteal, femoral pulses, probably none or very minimal. So blood is not going down. So if you ever get a newborn child and you're doing initial assessment and you're listening, doing your assessment, and you feel no pulses on the lower extremity, how are you going to say that's a coarctation of the aorta? And I did this once. I found one. You do what we call a 4-extremity blood pressure. You do the blood pressures on the lower extremities. So blood can hardly get down to the lower extremities. So blood pressures are lower. But the blood is going up. It's all the rest of it's going up. So the upper extremities are going to be higher. And then that blood's going to flow back into that left ventricle. And then where can it go? Up to the left atrium. And then where does it go? Into the lungs, and it fills fluid up. That's coarctation of the aorta. That's one of your tested diagnoses that you need to know. That means lower extremities are no pulses, lower blood pressures, upper extremities, bounding pulses, higher blood pressure, and you're probably going to see the lungs fill up with fluid, and you're going to become all of that respiratory distress along with it. So many times children we don't see. In fact, this coarctation aorta, I had a girl came back at 3 months old and they had not diagnosed it at birth. And she was going through poor feeding, tachypnea, tachycardia, poor weight gain, activity intolerance. She was developmentally delayed. She wasn't getting her nutrition because she was so tired. She couldn't eat, et cetera, et cetera. And when we looked at her and we finally did her echo, we did find she had coarctation of the aorta. So again, we had to, we did the fix, we did surgery on her. That's what needs to be done. So a nursing diagnosis for a child that has a condition which is limiting oxygen or making the blood not flow around the heart and the body the way it should, this is a great diagnosis. Cardiac congenital children are going to be working so hard at breathing, they have no extra energy to eat. So inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed or just to feed a bottle. Okay, changing the bottle is not going to difference from breast to bottle. That's not going to make a difference. It's this child is just working hard because of this kink in the aorta, fluid filling up in the lungs, and they're not getting all what they need. So the first thing we do is we look at the child. Nutritional status. Are they gaining weight? We know a child normally should be gaining a lot of weight, right? They gain a lot in the beginning, and if they're not, something's going on. We can look at their color. Are they cyanotic or are they pink? You can actually put your hand on a chest with a murmur, especially a ventricular septal defect. That's that little hole between those bottom two chambers. You're going to feel pow, pow on the chest. You can feel the vibration on your hands. And again, as we get older, you might see clubbing of fingers. That would be on a really bad congenital defect. Their heart, again, we're going to be looking at their chest, their abdomen, their pulses. We're going to look at their heart rate. Is it slow? Is it fast? Children can have slow and fast heart rates. I've actually put in pacemakers on an 18-month-old child that needed it due to low. Yeah, of course, that child's going to have multiple changes as they get bigger, but did have a pacemaker. Once we decide a kid has a congenital problem, like that girl, all of a sudden she came to us and we noticed that her echo came out and something was going on, coarctation. This child, when we suspect, we're going to go for cardiac catheterization. Now, cardiac catheterizations are not a big deal, but it is a procedure. And post-operatively, your biggest concern is hemorrhage. Now, they take two big catheters and put it in the right femoral artery and right femoral vein. So a big catheter's gone into the groin in the right leg, okay? And post-procedure, the first thing I always check is that dressing. And if you can imagine, most congenital defects are there at birth. So these are infants, these are neonates, these are small infants. And if they start bleeding out of that catheter site, they can hemorrhage out very quickly. So first of all, you check that. Well, what happens if it's bleeding? You're going to take two fingers and put it right above the insertion site, closer to the heart than to the toes, and give it a little bit of pressure there, okay? And that little bit of pressure, stops the blood, and then you call for help. If it's a little bit, they'll just redress it. If it's a lot, we might have to do a CBC, give blood. Anything can happen from that. All right, so then you look at it, the dressing is fine. We're going to be looking at the pulses in the lower extremities because they had something, in that femoral artery and vein, right? So checking the pulses, they might be decreased, but that's normal. We had something in there. So again, documenting it and giving it off in report, decreased pulses would be good. Of course, extremities, looking at them. And then we're going to be, are they going to give PO or are we going to be giving IV? And it depends on how alert the child is. And we always check blood glucose levels. Did they get too much fluid during the procedure? We didn't have sugar. Do they need sugar or too much? Again, we want a fluid balance with that glucose to know what's happening. So congenital heart defects in children, I never knew there was as many as there were. I never did until I worked in a cardiac intensive care unit. I had the pleasure of working with one of the most amazing surgeons who was doing all of these first time everythings, in the world. And it was interesting to do it with him. The most cause of congenital anomaly that we might see is actually that VSD. The heart has four chambers, the atrium on the top and the ventricle split by an atrium or a partition in the center. And when that septal, that is a little bit a hole in it, could be small, medium, or really large. And it's called, between the ventricles, a ventricular septal defect. Now, if it was the upper chambers, it's an atrial septal defect or ASD. Now, a VSD is the one that you can hear that big, usually you hear chikoon, chikoon, chikoon for a heartbeat, right? But a VSD is a, and you can hear it. That's what it sounds like. Now, you all just did a really neat discussion question on cognitive delayed. And I just want you all to know, I did put something there for you guys to read on it, some more information. But, trisomies can be a lot of numbers. I've actually seen a 9. There's 9, 11, 13, 15, 18, 21. There's all of these ones. And the thing that you need to know about them is the lower the number, the more severe the defect. Know that with these children, the trisomy children, they are at a very high risk for congenital heart disease. And of course, the most simple one would be a VSD. So shunting, all that you need to know with this slide to know is know that things go from high pressure and it wants to go to low pressure. Just like all the mucus here went to the ears, it wanted to get away. And it goes area of least resistance. Now, here are the defects. So what I want you to know about this. Well, I've already talked to you about an ASD and a VSD. It's a hole in their partition. So that means the left side can push over and flow to the right side. That's the area of least resistance. If you think about a drop of blood, it starts on the left side with big left ventricle pushing it out into the body. And then it just gets back to that right side and into the right atrium. So the right side is very low pressure. So that left side is going to push, if there's a hole, to the right side. What does that do? Well, it puts more blood going back into the lungs. It already come back through the lungs, but it's putting it back there again. So it's increased pulmonary blood flow. The obstruction, I've already talked to you about coarctation of the aorta. Everything goes back. Well, what if your aorta, the aortic valve, was stenosis, which means narrowed? Stenosis is a narrowing. Now, you're going to see again the same thing. Blood's going to go back, left ventricle, left atrium, into the lungs, same thing. Pulmonic stenosis, what's going to happen on the right side? Right ventricle, right atrium is going to swell, and usually your liver gets engorged. So these are obstructions. Now, the biggest of all the ones that are tested in HESES and CLEX is tetralogy of Fallot. Tetralogy of Fallot is when your pulmonary artery, which sits in the right ventricle, is working okay. Then all of a sudden it spasms, it closes, a piece of tissue closes the thing, and blood can't get into the lungs. So this turns a baby from a nice pink baby, and like that, they turn blue. I had a little boy named Nolan Ryan. Never forget his name. It's a baseball star's name. Nolan Ryan, this little boy had tetralogy of Fallot, and 5 a.m. one morning decided to have a tet spell on me. He was pink. I'm telling you, in 10 seconds, he went to O2 sats of 10, and he turned black, gray, purple, and it was scary. What do you do for tetralogy of Fallot? Well, something covered that pulmonary artery and stopped blood from going. So we do what we call a knee chest. We take the knees and put it up to the chest, like right away. If they're on their side, we put it on their side. If on their back, we put the knees up quick. And it just changes pressure in the chest, and it changes it in the abdomen, and it will pop it off and get the blood flowing again. That is considered a cyanotic heart defect. Now, transposition of great arteries, this mixed flow. Can you imagine the aorta and the pulmonary artery? They're switched. So we don't have blood going to the body. We only have it going to the lungs, and there's no mixing going on. That's transposition. Okay. Now, if we had transposition of the great arteries and we don't have blood going anywhere, we need to have something to put blood there. At birth, you have something called a patent ductus arteriosus. This is fetal circulation. This connects the pulmonary artery to the aorta. So it connects the lungs to the body. So I call the PDA an oxygen giver, right? If you need oxygen, you need an oxygen giver, which is your PDA, okay? PDA is something that we would keep open for transposition of the great arteries until we did surgery, because it's the oxygen giver. Because by itself, we're not mixing anything to the body to give oxygen with, okay? They say a PDA if you listen to it, there's a loud washing machine murmur, it's called. And you could hear it's like choo-choo, choo-choo, choo-choo. Like it's really like that agitation of a washing machine. So PDAs, if we need them open, we have to do something because fetal circulation is only when mommy's pregnant, right? So when mommy delivers the baby, this PDA normally goes away. They say 3 to 5 days. They say up to 21, but usually it's pretty quick. A couple days, it's gone. So what do we have to do if I need my oxygen giver? Well, we need to do something and we need to give some medicine. Now, at when the baby is born, mommy's prostaglandins is a hormone she has, and it keeps this duct open, this PDA duct open. And when mommy goes away, this hormone, prostaglandins, goes away. So if I want to keep this open, I have to put on a slow, continuous infusion of a synthetic prostaglandins, which we have, and it works great. What does prostaglandins do? Well, it's an oxygen giver, right? The PDA is oxygen giver. So it's good for oxygen saturation levels and it maintains cardiac output. That's what you need to know about prostaglandins. Now, what if you're born, this PDA is open, and for some reason it doesn't close, and you don't need an oxygen giver. So you need to close it. And that's when we give the indocin or indomethacin, and that closes up that PDA. Now, I used to love to give indomethacin because I would sit there and listen to the heart and listen to say, is that murmur going away as I'm giving this indomethacin? And you could hear it go away. Other thing is pulse pressures were really far apart, 60 over 18, not 60 over 40, which is normal. And that 18 will come back up to normal at 40 as the PDA closes. It's pretty neat to watch, actually. All right, we did that one. These are just extra pictures for you to look at. Now, congestive heart failure. How do I take care of congestive heart failure? Does it matter if it's right or left side? No. If you have congestive heart failure, you're going to have fluid in the lungs, you're not perfusing, and it needs to be straightened out. Now, it could be all of the fluid in the lungs. That lungs are completely full of fluid in this one here. So what is our goal? Well, a lot of time congestive heart failure, we can find out because there is a sudden increase in body weight. We do weigh our infants every day at the same time on the same scale to see if there's any difference. Now, if we're in congestive heart failure, we'll see a sudden increase in the weight because that's fluid the baby is retaining. As we start to treat this child and get rid of that extra fluid and strengthen the heart, we're going to see that weight decrease. So body weight, intake output is going to tell us how well we're doing if our heart is getting better. One of the things we do give is digoxin. What does digoxin do? It lowers and strengthens the heart. So now we've got a more effective, slower squeeze of the heart. It's a great drug. We use this on elderly 100-year-old people down to newborns, and we just do it mics per kilo, milligrams per kilo, and it works. And you were going to do the same thing that you do for adults. Count the apical for a minute, check electrolyte stage level, and again, vomiting might be the only thing that you do see. So again, digoxin, teaching parents how to look at heart rates and how to look at vomiting and what to do. Very important. Hypoxemia on your cyanotic heart diseases. Now, one of the worst of all the congenital heart defects is called a hypoplastic left heart. And O2 saturations at birth could be 70%. and that's okay. After first surgery, it might go to 80, 85%. And maybe after the third one, we go up to 90%. You sometimes have children that are never 100% perfused, but we're going to get them as best as we can. Now, when you have a child that doesn't have a O2 saturation where it should, what does the body do? It says, well, there's not enough oxygen go around in this body, so let me produce more red blood cells, because what do red blood cells do? It carries oxygen around to the body. So what happens? You're going to have a very elevated hemoglobin and hematocrit, but you still have the same oxygen because the body doesn't have any ability to make it more than what it was. So polycythemia is that extra hemoglobin hematocrit that the body's making because it feels like it's hypoxic. And then there's a picture of clubbing. Always, 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 always cardiac children and family. I'm telling you, these are probably some of the nicest parents. They want to learn, they want to know. So always, always plan and teach them everything we can. We already did cardiac cath, bacterial endocarditis. Usually this is some sort of infection. It will be treated, and this might be some prophylaxis before procedures. And then we sort of mentioned rheumatic fever before, but let's go over a little bit more. Know that rheumatic fever is due to a strep infection. It can affect the joints, the skin, the brain, and the heart. And of course, that chorea, that weird movement, can't control yourself. The only thing that we can't treat is permanent valve damage. Once it's damaged, it is damaged. But everything else, including the chorea, all the swollen joints, rash, all of that will go away. Children can get high cholesterol. We never knew that before, but now we're checking for it. As I said, we can have any heart rate on a child from slow to fast, and we're going to treat it the same way. Pulmonary artery hypertension. This is when your lungs are stiff, they don't want to work. And the problem with pulmonary artery hypertension is that a child with this, under a little bit of exercise and activity, will get short of breath because their lungs can't tolerate any more activity than just being quiet and just barely doing activities. Cardiomyopathy. This usually happens from a viral infection, believe it or not, where the heart muscle swells, it becomes floppy, and it doesn't work. And for a long time, they'll be sending these children in for what we call tune-ups. We'll put them on maybe some diuretics, maybe something to help the heart beat better, some infusions, some pills, whatever it needs just to tune up that heart. But it ends up usually with heart transplantations. Know that rejection is the largest reason for death. It's not infection, it's rejection. And then chest tubes in children. Know that this concept is anything in children that we need to do for them that's going to cause pain. Number one, always tell them it's going to hurt, because no matter what you do, taking out chest tubes is always going to hurt, even with a lot of medicines, but it's temporary. I worked adult ICU, cardiac ICU, and I worked night shift. And every morning at 6 a.m., the residents came around and we pulled chest tubes out of every open heart from the day before. So the adults have told me when it pulls, it's an intense burning, but it's not that long, like 10, 15 seconds, and then it's gone. But it's like, and then it goes away. Always medicate for pain for children, all right? That's the point. Take vital signs before and after. Tell them what's going to go on their level so they know what we're going to do. And always be honest. Please be honest. It's going to hurt. We're checking blood pressures earlier in children. We can prevent a lot of kidney diseases by doing this. And then Kawasaki disease, the only diagnosis you're going to give aspirin to. Kawasaki disease is when your vessels are inflamed in your body all over. And the one we're concerned about is the the heart and the coronary arteries and aneurysms forming. These children come in with fevers, rash, big red eyes. They come in with strawberry tongue, peeling of their palms and soles of their feet. This is again another virus here. So how do we treat it? Well, we give IV gamma globulins, IVIG. Let's boost the own body's immune system. And then we give high dose aspirin. Why do you think we give aspirin? Prevent clots. Inflammation of the vessels, little microembolus are going to be there. Let's prevent clots. Sometimes they use Coumadin, but we're taught aspirin. COVID, we know that came out. We know what it's all about. I don't even have to tell you more about that. We've already talked about shock, anaphylaxis. Know that it's always going to go airway, epinephrine. Septic shock is knowing. Do you know what the first couple signs of sepsis in a newborn child is? Apnea and bradycardia. Very short little, all of a sudden you start to see it. This child's becoming septic. And that's when we go and do the workup, start them on antibiotics. We don't even hesitate. It's apnea and bradycardias. Toxic shock is usually tampons and your adolescents. And then surgical closure of the oxygen giver, the PDA, would result in the following. It connects pulmonary artery to the aorta. So you cut that off. My oxygen giver is gone. What are you doing? I'm preventing oxygen blood from going back, aren't I? Because it's not coming the aorta, going back up to the heart. All right, let's do another Kahoot. We're almost there. I want you to know when we look at lungs and we, pulmonary, and we look at cardiac, I know you're scared to death of cardiac. If you can understand the concepts that I've put here, you're good. If you need any more help with it, let me know. Cardiac actually is my forte. That's where I probably the best. All right, who wants to win this one? Chloe, are you going to win this one for me? Here we go. I think there's 17 here, and then we're done for today. Oh, 21 of them. Why would a child with tetralogy of Fallot not gain weight at a normal weight? Remember, tetralogy of Fallot is a cyanotic heart disease where all of a sudden the kid goes blue. Your pulmonary artery gets covered, oxygen doesn't go. So what are you going to see? So inadequate oxygenation, which leads to decrease in energy. Absolutely, that's what it is. That's why they're not gaining weight. They're just working hard enough for their heart to beat at this point. What's the treatment for Kawasaki disease? Systemic vasculitis, and you worry about, aneurysms, coronary artery aneurysms. How do we treat it? So Kawasaki disease is a virus. So we're going to be given something to boost the immune system, the IVIG. And then we give aspirin, and aspirin is to prevent clots, okay? Methotrexate is for rheumatoid arthritis. Has nothing to do with Kawasaki. A multi. A clinical manifestation of Kawasaki disease is, I used to like to try to figure these kids out when they came into the ER. And they were very difficult. And usually the infectious disease doctor had to come down and figure out exactly. But it was pretty neat when you could say, hey, I think this one's Kawasaki. And they go, yeah, I think you're right here. Because they are not completely into all the symptoms yet. It's blistered, cracked palms. It's strawberry tongue. It's reddened eyes beyond redden, okay? And chorea is rheumatic fever. Don't mix up the conditions. Which of the following best describes the pathophysiology of Kawasaki disease? So, Kawasaki, multi-system vascularitis, which may affect the coronary arteries, which should be an aneurysm, okay? Again, it's the itis, it's that inflammation. That's why microembolus, that's why the aspirin. A multi. Why do you give aspirin to a child with Kawasaki? What do you think? So, aspirin is an anti-inflammatory, number one. It prevents clots or thins the blood. Absolutely. Pain relief, there's really not any pain involved with this. But if there was, I guess it could, but it's not really the priority. The priority is to thin the blood to prevent the clots. That's the absolute priority there. An abnormal hole between the right and left atrium is called a what? Okay. Upper atrium hole. It's an atrial septal defect. If it was a hole between the two ventricles, it's a ventricular septal defect. Okay. Those are words you need to know for this. What is the treatment for a TET spell? Tetraldiafilo. What's the treatment? I guess it depends on the age of the child for part of it. So treatment first is when you have a child in a TET spell, an infant, you would automatically need a chest. Older kids that haven't been repaired for whatever reason, all of a sudden you'll see them squat to the floor and they basically take care of themselves, and they prevent it. It just happens normally. But in infants, you would need chest them. A multi. Why is prostaglandins given to a child with transposition of the great arteries? Well, prostaglandins does what? It keeps open the PDA because mommy's prostaglandins is gone, right? And what is transposition? Well, transposition is the arteries are backwards. They're hooked up the wrong way. And prostin keeps PDA open, which is an oxygen giver. Oxygen giver, it helps with oxygenation, it maintains cardiac output. Remember, when we're talking about prostaglandins, any of this, there's no infection here. It's not to prevent endocarditis. It's not for infections. It's only to keep that oxygen giver, the PDAA, open. That's all it does. What's the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? So when you give indomethacin, what it does, it stops the prostaglandins from being secreted. That's what it was. But it closes the PDA. That's all it does. Indomethacin closes the PDA. You're going to see that murmur, that big washer machine murmur, is going to start to go away. Blood pressure is going to start getting to normal levels now. Transposition of the great arteries is so transposition, the great arteries are pulmonary artery and the aorta. They're switched. That's all that means. And that just means I need something to give oxygen to that body quick. I want my PDA open. What do I need to do? Give prostaglandins to keep it open because mommy's is gone now. When measuring blood pressures on four extremities of a child with coarctation of the aorta, you would expect what? You got a kink in the aorta, a coarctation. What are you going to see on blood pressures? Got a kink on the arch. It's narrowed. Blood can't go down there. So what are you going to see? You are going to see blood pressures lower in the legs because blood can't get there. But it's also going to be up in the arms. It's going to be higher in the arms. Early signs of heart failure in infants include infants, heart failures, early signs. One of the things that's pretty quick is poor feeding and sweating. They're working so hard, just breathing and heart beating. They're sweating, and then you put a bottle or a breast in their mouth, and they just can't handle it. So, poor feeding, sweating, those are your early signs that you see. A multi. Signs of heart failure in a 3-week-old child with congenital heart disease. What do you think you see? So, if you have heart failure, there's going to be edema, there's going to be swelling somewhere. Usually, heart failure goes right into the lungs. So, you'd be tachypnic and tachycardic. Weight gain, sudden weight gain is like one of those key things that you see. You're going to have a heart is hard, it's not beating well, so be hypotensive, and you probably will have cool extremities and not warm. A multi. Feeding the infant with heart failure. You got a child whose heart's not working well, and you got to feed them. What are you going to do? You don't want to tire them out, do you? So how are you going to give nutrition? So, what we'll do with heart failure, when we have a child in heart failure that can still eat by their mouth, okay? What we're going to do is increase the calorie count. So, usually formula is 20 calories per ounce. We can go up to 30 calories per ounce or more. So, we can, have them eat less and still get the same nutrition. Of course, holding them up so that they can breathe easier. Of course, we're going to be monitoring them, and if they can't take the whole thing down and they still need nutrition, we can lavage the rest of it, put a feeding tube in. So heart failure, big thing. Concentrate their formula. No more than 30 minutes on a feed ever on these children, okay? After a heart transplant, what's the leading reason children die? Rejection, rejection, rejection. Nursing care following a cardiac catheterization. So when we're talking cardiac catheterization, our big thing post the procedure is to check the insertion site for a hematoma. One of the things is never to bend that leg of that where they had that catheter into the right groin. So the right leg has to maintain straight, and they must be on bed rest for 24 hours, okay? So check the dressing, check the feet, and of course, they're keep that leg straight and no ambulating for 24 hours. Where is the patent ductus arteriosus? Fetal circulation. What does it connect? I call it an oxygen giver. So what is it? It connects the aorta to the pulmonary artery, goes the lungs to the body. As simple as that. A multi. What is a sign of digitoxicity in infants? In infants. Digitoxicity in infants. Nausea, vomiting, and a heart rate that is low. Tell me, can an infant tell you they're seeing yellow spots? No. And digitoxicity has nothing to do with infections. What are the signs and symptoms of heart failure in children? And it's all of the above. Fluid, heart doesn't beat right, shortness of breath, yes, tachypnea, tachycardia.
In my mind, I read that as a multi-select.
Which medication is commonly used to relieve unfundibular spasm during a TET spell, or what do you use for a TET spell? Sorry about that. Usually they use morphine, and morphine calms them down. Sometimes they also can use digoxin, but during this spasm, it's morphine, and then they'll place them on long-term digoxin to slow and strengthen that force of contraction. And last question, key to preventing post-op complications? And, the whole thing is keep the lungs going, right? And that's going to be with early ambulation. Now, how do you do that early ambulation? Of course, it's going to be that pain management, hydration, et cetera, et cetera. But it's getting them up, getting them out, getting them moving is the best thing. Number 3, Val. Good job, Val. Number 2, Madeline. Good job, Madeline. Number 1, drum roll, bing, Lizzie. Good job, Lizzie. And Shabab and Kevin. Good job, guys. All right, we're done for today. Know that, we have your discussion questions. Please, anybody who wants to give me their diagnosis, if it's already filled up, I don't want more than 2 or 3 of the same one. So if it's already filled up, you have to pick something else. You don't have to choose what's on the list in module 8. You can think of anything that is could be on a child, and you could do that diagnosis. So just let me know and I'll get with you. Thank you, guys. Glad to be back. Have a great evening. Bye.